This is Jose Merino, Editor-in-Chief of the Neurology family of journals. The Neurology podcast provides practical information to neurologists and other clinicians to help them provide better care for their patients. Thanks for listening and have a great week.
Hi, this is Jeff Ratliff from Thomas Jefferson University and with the Neurology podcast. I'm here with Michael van Es and Eva de Boer from University Medical Center in Utrecht in the Netherlands. Michael and Eva are co-authors on a study published in Neurology titled Primary Lateral Sclerosis, Implications for Diagnostic Criteria from a Natural History Study in the Netherlands. In this study, patients from a clinical cohort of suspected PLS were evaluated with the latest PLS consensus diagnostic criteria in an attempt to validate these criteria and determine how this elusive diagnosis can be best made. So, Michael, Eva, welcome to the podcast.
Thanks for having us.
Eva, I want to start off with you, and let's do a high-level overview here. What is the take-home message that you would want our listeners to learn about what this study teaches us about diagnosing PLS?
I think that the key takeaway is that diagnosing PLS is quite a challenging process in which clinical follow-up is very crucial. And based on our cohort study, we suggest that a diagnosis of PLS should be made after a 4-year disease duration, as we see that a lot of patients that have a disease duration shorter than 4 years, that they showed shorter survival and more conversion to ALS. And what we also saw is patients that presented with upper motor neuron symptoms in only one body region, that these patients specifically can also have progression of upper motor neuron symptoms to other regions over time. So this data altogether suggests that a more accurate diagnosis and providing patients with a more accurate prognosis is made if you take more time, because after 4 years, we see more people staying in a certain category. And also within a couple of years, you can also see that patients progress from having symptoms in one region to multiple regions.
Got it. So I hear the take-home message is slow down, take your time, acknowledge that those initial upper motor neuron symptoms can change distribution, but also the addition of those lower motor neuron symptoms and signs that would move someone towards an ALS diagnosis can also take time to develop. And we need to make sure that we're not rushing to this PLS diagnosis because there is some variability in how these patients evolve with time. Michael, I'm hoping you can get us on the same page and tell us why this study needed to be done. What are the challenges in making a diagnosis of PLS that validating these diagnostic criteria was hoping to address?
I think one of the hard things is that PLS is a rare disorder, and it's characterized by slowly progressive upper motor neuron signs. And the main challenge is that we diagnose PLS by exclusion, and that initially there can be significant phenotypic overlap with other disorders. So for instance, with ALS, in particular, if there's an upper motor neuron presentation initially, it can look a lot like PLS. And similarly, HSP, develops with upper motor neuron signs in the legs, tends to remain there, but over time it can spread to making the diagnosis PLS. So as we have no diagnostic biomarker or definitive test for PLS, the diagnosis does rely largely on follow-up and whether or not patients develop these additional signs and symptoms. So it's based on follow-up. Over the years, there have been multiple diagnostic criteria for PLS, and all of these have largely put a lot of emphasis on disease duration. And the most recent criteria are based on expert opinion. And although they seem to make a lot of sense, they have not been validated extensively. So that's what we set out to do in this study. And in this study, we had the opportunity to take the advantage of a natural history study that we started back in 2002. And in this study, we enrolled patients that were suspected of having PLS at the time. And we follow them up at 3 years and then 10 years after. And that gave us a lot of natural history data. Interestingly, we had patients who initially met the criteria for PLS, but also patients who did not. And so we saw that some of the patients that initially met the current criteria went on to develop ALS, whereas some of the patients that initially did not meet the criteria because they only had upper motor neuron signs in their legs went on to develop upper motor neuron signs in other regions and therefore did meet PLS. So I think the main thing this study is showing that if you take time and follow your patients for a very long period, it reveals what the diagnosis is, but you do need to have this long-term follow-up.
I think there's a lot there to summarize, and I think that was really helpful. And one thing I'm hearing is just to be mindful of what are the other things on this differential. So there's PLS, we've already mentioned, ALS, we've mentioned HSP or hereditary spastic paraplegia, and then there's other disorders that could also cause this progressive spasticity. And then again, with the lack of a true biomarker, we're required to use time as a diagnostic test in and of itself and to follow patients over time and see what the evolution is. And getting back to that first lesson that Ava highlighted of taking your time, don't rush to the diagnosis. And so, Ava, we've been talking about these diagnostic criteria. And so I guess it would be helpful to hear two things. One, Michael alluded to this cohort of patients with suspected PLS. So what are the clinical features of the patients that this criteria is being applied to, right? This patient walks into our clinic. On whom should we be suspecting PLS and looking to apply these criteria? And then the question would be, what are the criteria? What do we look to check off on these patients so that we can try to zero in on this diagnosis over time?
Okay, so I'll start off with telling more about the current criteria. So the current criteria are criteria that are consensus criteria, and they were formed in 2020. And the first important thing is that patients must be 25 years or older at diagnosis. And the most important thing, of course, is that patients have progressive upper motor neuron dysfunction. And these symptoms, they should occur in at least 2 body regions, of which the body regions can be Boer, or upper limbs or lower limbs. Apart from that, there are some things patients are not supposed to have. So sensory symptoms are not allowed, as well as active lower motor neuron signs, or an alternative diagnosis based on ancillary testing. For example, findings on MRI or blood or CSF that can give another diagnosis based on the symptoms of the patient. What is new in these criteria is that they define 2 levels of diagnostic certainty, namely probable PLS for the patients that have symptoms between 2 and 4 years, and definite PLS for patients that have symptoms for over 4 years. And the reason for this was that the current criteria aim to reduce the diagnostic delay and therefore also optimize therapeutic trial designs and reducing patients with a shorter diagnostic time, because the former criteria always had 3 or 4 years required symptom duration before a diagnosis could be made. So for the suspected patients, these are mostly patients that have symptoms shorter than 2 years, so they don't have the probable disease duration yet, or have symptoms in only one region, because the criteria really require them to have symptoms in 2 body regions. So I think that's the most important part.
Got it. So patients coming into the office, certainly if they're 25 or older, but maybe they don't have 2 body regions involved, but they have these progressive upper motor neuron signs and it's not been 2 years yet, we certainly can't make that PLS diagnosis at that time by these criteria. If we follow them and see progression to other body regions, we see them moving past that 2-year mark, we can start to say this is probable. And then once we're at that 4-year mark, and again, in the absence of sensory symptoms, lower motor neuron signs, or development of other exclusionary criteria, we increase our certainty with time, with the appropriate distribution and the appropriate amount of time and syndrome criteria that we're identifying, if I'm hearing you correct. So Michael, in diving into the methods of this study a little bit, so you looked at this cohort of patients with suspected PLS. And as you mentioned, this cohort goes back a couple of decades now, and looked at their evolution over time and used this lens of these 2020 consensus criteria that Ava just taught us about. And so what can you tell us about the patients who were in this cohort from the standpoint of their clinical features in terms of meeting those criteria off the bat, or maybe not quite meeting the criteria, but still being followed over time? What was the cohort like? What happened with the application of this criteria over time?
The study started in 2002, so obviously it predates the current criteria. So we had 86 patients, of which the attending neurologist thought that PLS was the most likely diagnosis. What we did was we saw those patients at their initial presentation, and when they came into the study, we saw them in between, but saw all of them at 3 years and then a 10 years time point, so a total of 13 years of follow-up. And looking at the initial cohort of patients, we had a total of 43 patients that would meet the current criteria, of which 6 would meet probable PLS, and then 37 would meet definite PLS. There were also 35 patients who had upper motor neuron signs in only one region, and then there were 8 who had a symptom duration shorter than 2 years. So we had patients that would meet the current criteria and patients that did not. So if we then look at the patients who did meet the criteria, so those 43, in 14% of those, we revised the diagnosis during follow-up. So 5 of those cases went on to develop ALS, and in one case, we made a genetic diagnosis of HSP. Conversely, we had in the group of patients that had upper motor neuron signs in only one region, over follow-up, see that they developed upper motor neuron signs in additional regions. And for the majority of patients, that was at the 3-year follow-up visit. So 11 of those patients had upper motor neuron signs in additional regions at 3 years. And then 6 cases had developed additional upper motor neuron signs when we saw them 10 years later. When we reevaluated those patients, we were obviously careful in revising diagnoses, and we based those on a number of things. One of them was obviously our neurological examination, where that was clinically detecting upper motor neuron signs in different regions or clinical signs of lower motor neuron loss, findings on needle EMG, where they had to meet the L-Escorial criteria for ALS. And then in some cases, it was also based on new insights into the family history. If you have such a long family or long follow-up, sometimes family members also develop a similar syndrome. And obviously, there have also been advances in genetic testing.
I wanted to ask a follow-up to that. It's occurring to me that obviously when this cohort started, I think we all agree that the availability both from laboratories and the costs associated with genetic testing has really changed a lot over this time. And so with regards to these criteria and thinking about genetic diagnoses and genes associated with HSP, is genetic testing something that, I guess in your expert opinion, should be explored at those early stages because it can effectively sort out these patients who probably have an HSP syndrome and are not PLS otherwise? What is now the role of gene testing when you have that clinical suspicion that maybe now is different than it was in 2002 when the cohort was launched?
Well, obviously, the possibilities for genetic testing now compared to 2002 have changed dramatically. In 2002, I think we looked at 1 or 2 genes by Sanger sequencing, and that was a humongous undertaking to even do that within the context of this study. I think that the issue of genetic testing with respect to what the position is in the diagnostic workup of PLS is still controversial. The current criteria actually advise not to do an extensive genetic workup. My personal opinion is different. It's also based on another study on which Ava is the first author, but also a number of smaller studies from different groups where they've looked at ALS mutations in ALS genes and HSP genes in patients suspected of having PLS. And you do find these mutations in, say, 10 to 20% of patients. So I think there is a possibility that a genetic test can provide you with a diagnosis sooner than the 4 or 5 years of follow-up that might be required. So I think there is a place for genetic testing, but I think there's no consensus on what that is currently.
It sounds like we'll have to bring you back for a separate podcast, really diving into the pros and cons of genetic diagnostic testing, because it sounds like there's a rich topic there. But in keeping us in this paper, and Ava, I'm hoping we can dive in a little bit more into what Michael talked about. He mentioned that within the cohort, there are patients who met criteria off the bat. There are patients who did not meet the criteria off the bat. And then, as he said, there were revisions in diagnosis. Some patients did go on to have an ALS diagnosis or an HSP diagnosis, or they did not meet criteria and then they diverged. And so I guess my question is, are there clinical features present early on that can help predict conversion? Or should we get back to that lesson you started us off with and say, don't do that, wait and take your time and don't try to predict the future because there is an unpredictability of how these patients' diagnosis is going to be applied or revised or develop with enough time?
In our study, we did find some things that were predictive of a conversion to ALS, and it may seem quite obvious, but patients that converted to ALS tended to have a shorter symptom duration at time of inclusion, and they also showed faster functional decline. And for the latter, I think we must say that faster functional decline was not as fast as we usually see in ALS. So in the larger groups, we saw that it was a bit faster, but it wasn't a monthly decline that you would maybe expect with a patient with ALS, where you see them in a few months and then think, wow, I see a very big difference when I'm examining them neurologically. As for patients that received the diagnosis of HSP, this was, as Michael said, mostly based on insight over time regarding family history or also genetic testing. So unfortunately, I cannot provide you with any symptoms that are very distinguishing for these patients in the clinic. But therefore, our conclusion is, as you already mentioned earlier, that it is very difficult to diagnose someone at a very early stage. Doing this could also maybe lead to premature diagnostic closure, and therefore we do recommend to follow up patients during the first years and at least wait for 4 years to set a diagnosis of PLS. And looking at the other patients, so the patients that did not meet the criteria due to having symptoms longer than 2 years, but only in one region, we also found that this is also a specific group you should follow up on regularly because they may develop symptoms in other regions over time. So they may also meet the criteria for PLS at a later point. All the patients should be followed up on longer. So unfortunately, no specific clear answer.
It sounds like maybe if the rate of progression is accelerated, that might at least raise some red flags that maybe this is more likely to some degree to progress towards ALS, but not with firm diagnostic certainty. But largely, we need to monitor and acknowledge that symptoms, whether they're meeting criteria or not, are going to evolve over time, and that the lesson that we keep coming back to is time and observation and seeing these patients repeatedly and maybe gaining some of those insights about family history or genetic testing are also going to be important. I think, Michael, you had something to add too, I think.
Yeah, so I just wanted to add a little bit to what Ava said about the rate of decline. In our study, we looked at the ALS-FRSR score, which is a disability scale expressed where generally ALS patients tend to decline on average about a point per month. And then the patients we have in this study, they declined, say, with 0.3 to 0.1 points per month. There is a difference. The ones that were declining with, say, 0.4 point per month more likely to go on to develop ALS. But the rate of progression is still very slow compared to what you would observe in an ALS patient. So it's not that when they come into the office, it's obvious that they're declining at a different rate than your other patients.
Got it. I think that's helpful. The difference between statistical significant decline when you're looking at the numbers versus what can we detect clinically and observed change in decline. Ava, what are your thoughts?
We also look at survival of these patient groups within this study. And when looking at the survival curves, we did find that there were big differences, especially in the patients that presented with a short period of time, so that didn't even meet the criteria. So had symptoms for shorter than 2 years. These patients, as well as the patients within the probable PLS group, so the 2 to 4 years group, they had a shorter survival compared to the patients with symptoms for longer than 4 years or having symptoms of only, for example, the legs. I think that one of the important things for this follow-up, because of course as a neurologist you would like to provide your patient with certainty as quickly as possible, but one of the reasons we really think that this is important is that you don't want to give a patient an idea of false sense of security with patients by saying, well, we think you have PLS, but then actually turning out to be ALS a year later, because that's a big difference in survival.
Yeah, I think all of these cautions, I think, are very important. And we don't want to, as you said, reach a premature diagnostic closure for these patients because it absolutely does change their perspective, their planning, the care that we're delivering to. And I'm glad you mentioned that clinical context. And I want to wrap us up and turn to you, Michael, and bring the lessons from this study into clinic. And I'm hoping you can teach us a little bit about how you personally have changed your own approach to diagnosing PLS and making this diagnosis in practice after doing the study. What did you learn and how are you bringing it into the patient clinics that you're in?
So the two things that I think I really incorporated in my clinical practice are the observation that there's patients who would meet criteria for PLS but then develop ALS, and those who seem to have an HSP phenotype but then go on to develop PLS, is that there's a period of diagnostic uncertainty. And I've become reluctant to discuss a definitive diagnosis before a symptom duration of 4 years. And what I've started to do is actually transparently discuss that there is this diagnostic uncertainty. So I discussed that an upper motor neuron syndrome has a very broad differential diagnosis, that we've eliminated a lot of things and that we're left with few options, that it could be PLS, it could be ALS, sometimes it could be HSP. And then depending on where the symptoms are in the body, that also structures that differential diagnosis. So people who have slowly progressive upper motor neuron signs in the legs, your differential tends to be more HSP versus PLS, whereas if there's also upper motor neuron signs in multiple regions, it's more PLS versus ALS. So where the symptoms are and the symptom duration guide your differential diagnosis, but it's also what you need to discuss with your patient. So I try and talk the patients through what the thinking is, but also try to help them understand that it takes time to reach a diagnosis.
I think that's really important. And it sounds like just transparent communication, telling patients this is not something we're going to necessarily know before, as you said, this 4-year window has progressed. And yes, maybe new data comes to our attention, development of lower motor neuron signs, or something's going to change in that 4-year window. But in that period of time, we're going to watch, we're going to clinically monitor and continue to provide care, but we're not going to jump to a diagnostic conclusion. And preparing patients for that, it sounds like, is the lesson from this that I'm hearing from you. Well, thank you both. I've been speaking with Michael Van Ness and Eva de Boer from University Medical Center in Utrecht in the Netherlands about their paper, which was published in the June 10 issue of Neurology. And that paper is titled Primary Lateral Sclerosis, Implications for Diagnostic Criteria from a Natural History Study in the Netherlands. Eva, Michael, thanks so much for teaching us today and talking with us.
Thank you so much for having us today.
This is Stacey Clardy, your podcast editor. If you've enjoyed the podcast, please take a few moments to subscribe, rate, and review the Neurology Podcast through Apple Podcasts, Google Podcasts, Spotify, or wherever you listen. And remember, you can always head to neurology.org/podcast for our full list of past episodes. Or you can also search by keyword in your podcast app for any neurology-specific topics you want to learn about.